Hey everyone, Hesham Hasabali here with Healthcare Musings. Happy to have you with me. I'm reflecting on the last two conversations I had in my Great Minds in Medicine series. And it brought up the issue of healthcare and waste, quote unquote, in healthcare and fixing the quote unquote waste in healthcare. And the reason I put the word waste in quotes is because it can be misconstrued. For example, Dr. Bessler, Rob Bessler, in our conversation about waste, quote unquote, waste in the healthcare system, he said this, quote, "It's making sure the right patients are getting the care." And parenthetically, because life is a terminal illness, and making sure families have those difficult conversations about goals of care in advance, unquote. And we were talking about, like, how can I, as a critical care physician, help fix the quote-unquote waste in healthcare. Dr. Greg Johnson, who we just had the conversation recently, he is a chief physician executive for Unity Point Health and used to be the chief executive officer of hospital medicine for Sound Physicians. Dr. Bessler was the founder of Sound Physicians, and now he's the CEO of Honest Medical Group. Dr. Johnson said this: so many patients are like, no, I want to be around my family, I want to be at home, and engaging in those conversations to understand that does mean we are not going to be doing certain things, unquote. He also said, quote, "Engaging with our patients in that kind of dialogue suddenly makes us more compassionate. It does allow us to care for our scarce resources in a way that is more meaningful and, candidly, brings more meaning to what we do as a healthcare system and physicians within that healthcare system," unquote. And so that's a very interesting reflection. So when we have goals of care conversations with our patients, which should ideally be done in the primary care physician's office, when it reaches me, me in the intensive care unit as a critical care specialist, if I am doing a goals of care conversation, it is way too late. It should not have to fall on an intensivist like myself and my partners and colleagues to have a goals of care conversation. And sadly, many times it does fall on the intensivist, the critical care specialist, to have those goals of care conversations because they're not being had in the primary care physician's office. And Dr. Johnson mentioned during our conversation that those discussions in the outpatient setting need to be paid for. They need to be reimbursed. And I think now the Centers for Medicare and Medicaid Services do reimburse for those conversations, and it's a great start, and it's something that's really important. But they have to be, and they have to be had in the primary care setting, not in the intensive care unit. And if I ask a patient or their family, if mom or dad or sister or brother or son, sadly, was standing where I'm standing and seeing themselves in the hospital bed, what would they say? If the family in their heart of hearts understands that they would not want this, then it's my job as his doctor not to care for that patient using aggressive artificial life support. And so it's providing the right care at the right time. And if a patient does not want to be mechanically ventilated and fed through a tube and have CPR all the way to their death, then we are in essence not providing care, but it's care that's inconsistent with their values and preferences. And so it's reducing quote unquote waste. Yeah, and I put that in quotes. Caring for a patient, even aggressively in the intensive care unit, is not waste if that care, and it's artificial and aggressive, is consistent with that patient's values and preferences. It's not waste. If, however, that care is not consistent with the patient's values and preferences, then it is quote-unquote waste. We are doing things to patients that they don't want us to do. And like Dr. Johnson said, it's important for us in the healthcare system to do things for people and not to people. Right now, the payment structure is that we get more pay when we do more things to people. we have to start learning, and I loved how he said that, we have to start learning to do things for people and not to people. And so when we, and it starts in the primary care office, it starts way before a patient, God forbid, lands in the intensive care unit. And at the same time, when we have those conversations, what we're doing is we are quote unquote, preventing waste, meaning that we are saving the patient from getting care that's inconsistent with their values and preferences, and taking those resources and putting them somewhere else. Because unfortunately, resources is a zero-sum game. If patient A in room 101 is using those resources, I cannot take those resources and give it to patient B in room 102. They're mutually exclusive. If the patient in patient A in room 101 does not want all that care, then those resources can go to another patient who would more benefit from those resources. And so when we talk about goals of care in the primary care physician's office, way before someone, God forbid, lands in the ICU, and if necessary, at the bedside in the ICU, what we're doing is we are providing compassionate care. We are working to provide care consistent with our patients' values and preferences, within their red lines, within their goals, and more importantly, we are preserving the resources of the healthcare system. So to me, it's a win-win-win-win situation. Thanks so much for your time and attention, and until next time, this is Dr. Hashem Hasabala signing off on Healthcare Musings.